Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
Next patient is a 73-year-old former smoker with early-stage lung adenocarcinoma, had undergone a lobectomy and adjuvant cis-pemetrexed, but relapsed with metastatic disease extensively, bones, lung, and adrenal glands, less than a year after completing adjuvant therapy. Has hip pain, performance status of 1, and a past medical history of hypertension, type 2 diabetes, and a history of a prior pulmonary embolus. Quit smoking decades ago. What would your approach be for treating somebody who, let's say, does not have, in fact, I think we have the diagnostic workup, but we don't have imaging. So widespread disease at this point. It's not that long. It's less than a year since completion of the adjuvant therapy. And this patient has a KRAS G12C as well as STK11 mutation. I would say this is pretty largely in the systemic therapy realm right now. So, Ram, what would you be inclined to favor for this patient who has gotten relatively recent chemo and now has progressed through it in a very multifocal way?
And more importantly, when you look at the molecular profile, the patient's PD-L1 expression is 0.
Yes, sorry, I didn't cover
that. The patient also has a KRAS G12C mutation. Now, for G12C mutation, there are promising therapies that are being studied, and we have seen early reports. For instance, sotorasib, which is a KRAS G12C inhibitor, seemed to have a response rate of 35%, disease control rate of over 80%, and a median PFS of about 7 months. So that would be a consideration for this patient as part of a clinical trial now or shortly after first-line therapy. The fact that the patient also has an STK11 mutation tends to portend that immunotherapy may not be associated with great outcomes, but I still think that it's reasonable to proceed in that direction. Carbo-pemetrexed-based regimen with pembrolizumab would be one approach. Ipi-Nivo in a PD-L1 negative patients, even though the FDA label is specifically for PD-L1 positive patients, I think is particularly relevant in the PD-L1 negative patient population. So one could go with the Checkmate 9LA approach, which is 2 cycles of chemo with Ipi-Nivo in this particular patient situation, where you're trying to get the best of both worlds with chemo and a combination immunotherapy approach in a situation where PD-1 or PD-L1 alone may not give us the kind of results that we're looking for. But I would highly encourage the physician to look for sites close by where the G12C inhibitors are being studied so we can get this patient on that trial.
And I agree that though we are likely to have sotorasib approved in the near future, it's not an agent or a class yet that we've seen the kind of results that would lead us to favor it as first line. This is not first line anymore. So I would say, any other comments from other panelists? Otherwise, I would just summarize, if I can, I'll go back to the preceding slide. I'll summarize to say that a difficult case, and one in which we would likely favor a chemoimmunotherapy approach, as if it's first line, something like Keynote 189, or an ipi-nivo based chemotherapy, even potentially with chemo. Yes, now that we have Checkmate 9LA, and as well that knowing that we have the KRAS G12C mutation and both a commercially available agent, likely available soon, and clinical trials, that would be a very compelling option to try to pursue in a timely way, especially if this cancer has been progressing at a significant clip.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
So we've had some exciting updates, specifically in the KRAS G12C space. We finally have drugs for an alteration that was considered undruggable. The first one, of course, is sotorasib, a drug that is now approved for patients that are KRAS G12C can be done in the second line. And this is based on the CodeBreak 100 trial looking at single agent sotorasib at 960 milligrams that was given again for patients who had progressed on prior therapies. And importantly, the response rate was 37%. The median duration of response was 11 months. And if you look at the median progression-free survival was 6.8 months. And the median OS at the time of receipt of this drug, remember, this is not first line. This was given in a highly pretreated group of patients, either second line or third line and beyond. The median overall survival was 12.5 months. So because of CodeBreak 100, sotorasib was approved. This drug does have toxicities, but those toxicities are fairly well tolerated. You know, the treatment emergent adverse events, grade 3 from this study, there were 20% of these patients, but very few patients that had treatment discontinuation. The most common being because of these treatment emergent adverse events. The most common being diarrhea, nausea, and LFT abnormalities. The second study that we learned about at ASCO 2022 was adagrasib. And this is yet another KRAS G12C inhibitor. And similar to the CodeBreak 100 study, this was a drug looking at patients who had had prior treatment with checkpoint inhibitor in combination or in sequence of chemotherapy. So this was a pre-treated group of patients receiving adagrasib 600 milligrams twice a day as single agent. This was a phase 2 study, the primary endpoint being objective response. And the objective response was very similar to what we saw with sotorasib. It was 43%. Remember, sotorasib was 38%. That's encouraging. Many of these responses are still ongoing. Median PFS, not that far off from what we saw to sotorasib, 6.5 months. Median OS, not that far off from what we saw with sotorasib, 12.6 months. Perhaps this drug is a little better tolerated from sotorasib. Again, diarrhea, nausea, LFT abnormalities seem to be the most common, but a pretty well tolerated drug. So I think based on this, at least in August 2022, that we will soon have an approval for adagrasib. Right now, sotorasib is the standard, but we may have another option in our therapeutic armamentarium, making it very exciting right now to treat patients with advanced non-small cell lung cancer.